Assalamu alaikum. Welcome to my channel, your go-to destination for comprehensive dental education and tips. I'm Dr. Ayesha, and I'm thrilled to embark on this journey with you. This channel is designed to empower you with the information that you need to achieve your goal of successfully clearing your exam. We would be doing exam-based discussion, and I'll keep on marking important VCQ and Viva questions, inshallah. All right, let's dive in and explore the fascinating world of orthodontics together. Okay, before we begin with our chapter, I would like to discuss what is the importance of orthodontics. It's often asked in VCQs, so if there is option aesthetics, go for it. Otherwise, the next two were function and speech. Like we perform orthodontics for basically three functions. Number one, aesthetic. Number two, function. And number three, speech. So any of them can be the correct answer in your PCQ. All right. So today we will be discussing about malocclusion and dentofacial deformity in contemporary society. Firstly, I would like to discuss about the definition of malocclusion. So, it is basically a condition in which there is a deflection from the normal relation of the teeth to other teeth in the same arch and or the teeth in the opposing arch. All right, that is called malocclusion. And we have got several classifications about malocclusion, but the Engels classification of malocclusion that was proposed in 1890s was an important step in the development of orthodontics because it is not only divided into major types of malocclusion but also include the first very clear and very simple definition of normal occlusion in the natural dentition. Basically, the Engels postulate was that the upper first molar, maxillary first molar were the key to occlusion, and that the upper and lower molars should be related so that the mesiobuccal cusp of the upper molar occludes in the buccal groove of the lower molar, and that the teeth were arranged on a smoothly curving line of occlusion. This molar relationship existed, then normal occlusion will be the results. As you can see here, if I maximize it, I've highlighted some important points that you should also mark on your books. We might be asked an OSPE or Viva questions, and there is high chance of being asked in VCQ exams, right? The key to occlusion is upper first molar. Basically, the mesiobuccal cusp of the upper first molar is occluding in the buccal roof of the lower mandibular molar, right? This is normal classification, normal occlusion. But there is also one thing to be noted, that smoothly curving line of occlusion means the line of occlusion will be smooth, right? What is line of occlusion? Let's discuss it first. Here you can see the image. The line of occlusion is smooth catenary curve passing through the central fossa of each upper molars and across the cingulum of the upper canines and incisor teeth. The same line runs along the buccal cusp of the incisor edges of the lower teeth, thus specifying the occlusion as well as interarch relationship. Once the molar position is established, means when the teeth are in occlusion, this is the line of occlusion where the teeth are coming in contact. It should be smooth, right? Then it would be classified into normal occlusion. If this line of occlusion is not smooth, then it would be counted in malocclusion class 1, 2, or maybe 3, depending on the molar relationship, right? Molar relationship. Engels then described three classes of malocclusion based on the occlusion relationship of the first molar. All right. In class 1, as you can see in the figure, let me get you to that figure first. Here you go. As you can see, there is a normal line of occlusion smooth curve, and the mesiobuccal cusp of the maxillary first molar is occluding in the buccal groove of the mandibular first molar. This is normal occlusion. If we talk about class 1 malocclusion, class 1 malocclusion, the mesiobuccal cusp of the maxillary first molar is occluding in the buccal groove of the mandibular first molar. This buccal groove is not shown clearly because the tooth is in occlusion, so it's hiding the buccal groove, right? Here you can see a slight line of buccal groove, right? Okay. So class 1 molar relationship is present in class 1 malocclusion. But why is it called malocclusion? Because the line of occlusion is not correct, right? The arrangement of teeth in the occlusion are not properly arranged. If we talk about class 2 malocclusion, the mesiobuccal cusp of the maxillary first molar is lying ahead of the mandibular first molar buccal groove, right? Here you can see the buccal groove is here, and the occluded mesiobuccal cusp is ahead of the groove, right? So this is class 2 malocclusion in which the maxillary dentition is ahead of the mandibular. And as you can see, the line of occlusion is also disturbed. It might also be possible that the line of occlusion is not disturbed. It might be well aligned like as there you can see, right? So, but still we will look for the molar relationship. Here we have class 3 malocclusion. In class 3 malocclusion, class 3 is basically for molar and malocclusion is the line of curvature is not properly following. The line of occlusion is not properly following. Right. So this is the mesiobuccal cusp that is occluding on the distal cusp of the mandibular first molar, not in the buccal groove. So it is behind the buccal groove. This is class 3 malocclusion. The line of occlusion can be smooth. It could not be like that it's always irregular. It should be considered. Okay, next. You can also go through these content for for knowledge purpose and if you want to, but I'm just discussing over there the very important OSPI, YY, and BCQ related points, right? So this was the most repeatedly asked question, that what is the primary treatment goal of Engel's paradigm test ideal dental occlusion is the answer, right? So that was asked in the BCQs several times before, so I thought I should mention it. You can also go through this whole table. It might be helpful for you. All right. Next, incisor irregularity index. So what basically they are telling us is that the incisor irregularity is usually expressed as in irregularity index, the total of the millimeter distance from the contact point on each incisor to the tooth contact point that it should touch. That means there are certain points on which the tooth normally are in contact, but in this irregular arrangement of incisor, the two are contacting at other points as well. So that is the distance between the exact real point to the point it is in contact. Right? So it is irregularity index. Okay, diastema, the most favorite questions for the BCQ for OSP and YY. It is basically a space between the adjacent teeth and mostly between the central incisors, right? Maxillary midline diastema is relatively common, especially during the mixed dentition in childhood, and disappears or decreases in width as permanent canines erupt, right? Spontaneous correction of childhood diastema most likely when its width is less than 2 mm, but if it is more than 2 mm, then in future we have to go for the orthodontic closure of this piece, right? Basic concept is that when the maxillary central incisors erupt and there is lateral incisors erupting or erupted and canine is over there, right? When it erupts, it pushes the roots of the lateral incisor push the root of the central incisor, causing it to diverge mesiodistally, right? When the canine comes in occlusion, the pressure on the root of the lateral incisor is relieved, so the pressure on the root of the central incisor is relieved slightly and then aligning the teeth in the arch so it will decrease the diastema. If it is less than 2 mm, it will spontaneously disappear. Next, posterior crossbite exists when the maxillary posterior teeth are lingually positioned. Posterior crossbite. Crossbite. What is crossbite? Normal occlusion, the buccal cusp of the maxillary teeth are hiding the buccal cusp of the mandibular teeth. But in this condition, the crossbite condition, you can see the buccal cusp of the maxillary dentition is hidden by the buccal cusp of the mandibular dentition. Alright. So when the maxillary posterior teeth are lingually positioned, maxillary posterior teeth are lingually positioned towards the palate, like they are reclining towards the palate. Related to the mandibular teeth, as in this patient, posterior crossbite most often reflects a narrow maxillary dental arch. Means if there might be a possible chance that the maxilla is not wide enough, the arch is narrow, causing this condition. But can arise from other causes as well. And as you can see, there is an anterior crossbite as well. The mandibular teeth are hiding or covering the lateral incisor, right? Ideally, it should be hiding the lower ones, just like central incisors. So, another very important OSPI, Viva, and BCQ question, like they might ask it to define you in OSPI or Viva, and there may be a chance of coming in BCQ that what is the normal range of overjet and overbite. So here you go. The mnemonic for the overjet is, have you seen ever a jet flying in the air? It flies in a horizontal direction. So overjet is defined. So jet is basically the part of mnemonic. Overjet is defined as horizontal overlap of the incisors. Means the maxillary incisor is horizontally ahead or overlapping the incisors. The mandible is so far behind. Normally the incisors are in contact, right? Normally they should be in contact, the tooth will be right there, right? Is so far behind. So only the thickness of the incisor edge, there is only a thickness ahead. Upper incisors are ahead of the lower, but only the thickness of the lower incisor edges. Means there should be only a minimum of 2 to 3 mm overjet, but as you can see, there is approximately 8 mm, 8 to 9 mm of overjet you can see here, right? If the lower incisors are in front of the upper incisors, the condition is reverse overjet or anterior cross bite. Reverse overjet means this mandibular tooth will go ahead of this maxillary, hiding it, right? So that would be termed as reverse overjet. Overjet, this condition is overjet, and if it is reverse, mandible goes ahead and maxillary teeth goes behind, it would be reverse overjet. Next we have overbite. This is also, I've drawn it for make it easier to you. Like overjet normally is 1 to 2, and overbite is 2 to 3. If you remember this triangle and this overjet is there and overbite is on the y-axis overjet and on the x-axis overbite. So it would be easy to remember you the normal range 1 to 2 and then overbite is 2 to 3 mm. Overbite is basically the vertical overlap. Vertically overlapping the incisor. Maxillary incisor is vertically overlapping the mandibular incisors. Normally, the lower incisor edges contact the lingual surface of the upper incisors above or near the cingulum. This is the cingulum, right? If you know the anatomy, this is the cingulum. So the inside, this is the incisor ledge of mandibular molar. It is near the cingulum or below the cingulum, right? Above or below the cingulum is the normal relationship. If the incisor is not contacting over there and it is going behind the cingulum towards the root and or maybe touching the palate, that would be deep overbite, a deep bite. All right. So overbite is defined as the vertical overlap of the incisors. Normally, the lower incisor is contact the lingual surface of the upper incisors at or above the cingulum. That is normally there is 1 to 2 mm of the overbite. In open bite, there is no vertical overlap. As you can see there, the teeth are not coming in contact. There is an open bite. There is no vertical overlap. There should be a vertical overlap of 1 to 2 mm. That is normal, but there is no overlap. So this is open bite. Vertical separation of the incisors is measured to quantify this severity. Means we will measure it that how much there is an open bite. Then we will quantify it at how much severe the condition is. Normally, occlusion relationships are considered in three planes, right? I marked it over there so that you guys can also mark on your books for authentic learning. So, lingual posterior cross bite. Firstly, occlusion relationship must be considered in three planes of space. What are these three planes? The transverse plane, right? The anterior posterior plane and the vertical plane. If we talk about transverse plane, there is posterior crossbite like maxillary deficiency causes the posterior crossbite. There is a transverse relationship we are looking in crossbites, right? Next we have anterior posterior, means if the tooth, maxillary tooth are ahead or they are far behind the mandibular tooth, like the overjet and the reverse overjet, it would be counted in anterior posterior deviation, right? Then we have vertical deviations in which we will discuss about the overbite, deep bite, open bite, vertical relationship of the tooth, right? So these are three planes. Next, what is pseudo class 3? We have discussed normal class 1, normal class, then class 1, normal occlusion, class 1 malocclusion, class 2 malocclusion, and then class 3 malocclusion. All these three, 1, 2, and 3 are malocclusion, and normal classification is the first one, right? So pseudo class 3 is also a type of malocclusion in which there is a shift into anterior crossbite because of incisor interference. What basically means is that the patient is having class 1 malocclusion, means the molar is in correct relationship. The mesiobuccal cusp of the upper molar is in the buccal groove, lying in the buccal groove of the mandibular first molar, but the line of occlusion is not normal. It's causing the interference in biting. So the patient is keeping the mandible ahead intentionally. That is called pseudo class 3, representing as a class 3 patient in which the mandibular teeth are ahead of the maxillary teeth, right? So the patient is shifting the mandible anteriorly, causing the crossbite because of the incisor interference, right? Incisors are malaligned, they are coming in premature contacts, causing the patient irritation or pain. So he's or she is keeping the mandible ahead intentionally. So that would be as class 3 malocclusion, pseudo class 3 malocclusion, right? It's not a true. So that's why we are using pseudo means false, false class 3 malocclusion. So when the patient presents with you like this, you should ask the patient to bite from the posterior teeth so that you can rule it out. That is it a pseudo class 3 or is it true class 3 malocclusion?